and clearly maintain the trigger points in the low back. So one of the things you have to do as part of the full treatment is to look to make sure that this is not part of the problem. Once you've done those first two, look for piriformis trigger points and gluteus minimus trigger points if the pain radiates down the back of the leg. If the pain skips the knee, the piriformis trigger point is the most likely culprit, since that is the referral pattern from the trigger point in the piriformis. If the pain includes the knee, there's likely entrapment of the sciatic nerve by the piriformis muscle. If so, you can inactivate the trigger point with the laser, and then, if necessary, treat the sciatic nerve with the laser and or appropriate medications. You can usually find the sciatic nerve coming out of the sciatic notch right down the middle behind the piriformis muscle. As you'll see from one of the pictures, the sciatic nerve can go either below, above, or through the piriformis muscle. And you have to treat that either with the laser, and if that works, the patient is very pleased. You may have to have that injected with a steroid or use Pennsaid or other medications that will go through the skin. When you see a patient that has patchy sensory deficits, that's a clue that there's clearly some myofascial problem going on in the low back. Weakness that the patient has, if it's severe, such as a foot drop, that's probably a nerve problem. But if its intensity is mild, it may be myofascial in origin, since tight muscles are weaker. If you remember your high school physics, that the lever arm is shorter, and therefore the muscle in this case, when it's tight and shortened, is weaker, even though there may not be any atrophy whatsoever. And finally, you want to treat most of the trigger points with 3 cycles of the ML830 cold laser. Occasionally 2 or 4 will be required. Before going to 5, palpate the trigger point again to see if it's been inactivated, and if it has, you don't need to go further. Locating a trigger point either by pincer movement and then running your finger over the trigger point. This is the way you would find it in the latissimus dorsi. This is just surface palpation, where you might find this in the infraspinatus muscle. This would be the way you would sort of pluck this trigger point and get a twitch response. You'd find it this way also with the upper trapezius muscle. Again, we talked about the treatment of back pain with the iliocostalis, which you'll usually find actually a little closer, right in here at the bottom of the ribs, and it attaches to the top of the pelvic rim, and it refers down into the buttock, and frequently maintains all the trigger points here and down in the top of the leg. Quadratus lumborum, you can see the pattern here. Sorry, I moved that forward. It's the primary muscle that helps to bend and twist the patient. This is often the muscle that causes pain, back pain in golfers because of the movement of the golf swing. Often it absolutely replicates the signs and symptoms of an L4, L5 radiculopathy. So you have to be very careful about evaluating those patients. The other area which is not shown here is that you may also be getting some groin pain and lateral abdominal pain to make the examining physician feel as though you have a kidney stone. And then they do a KUB of the abdomen, and you find that there's no kidney stone. But examine this muscle always before you make a diagnosis of a kidney stone. And then these are the trigger points in the gluteus maximus. You'll find a number of them all over the most superficial and the largest muscle in the gluteal area. These are the reference zones. These are the area of the trigger points. The primary trigger point's often located right over the ischium and is often presented as a symptom of inability to sit without significant pain. And the gluteus medius is here, the trigger points, and you'll see where the reference zone is right over the sacrum and up along the edge of the sacrum, depending on which trigger point you're finding. The gluteus minimus is usually seen as an active trigger point when the patient says, every time I put weight on my leg, I get this pain that goes down either the side or the back. This is, Dr. Travell called this pseudosciatica, where you get pain coming down this way, the back of the leg, but again, it sort of skips the knee. And if it's lateral, sometimes if you see both the anterior and the posterior portion, you have both a lateral and a posterior pain pattern, and this looks very much like sciatica. And of course, the multifidi, for low back pain, you'll find usually more sacral pain, sometimes in a very sort of a very close limited pain center right at the mid portion of the low back at L2, L3 area. The iliopsoas pain, the trigger point is in the psoas muscle here. Luckily, it's a very rare trigger point to find. It's almost impossible to get to, even with a fluoroscope, unless a patient is very, very thin, and even then one hesitates to put any kind of a needle back here, since the aorta and the vena cava lie right here. And if you try to hit that trigger point, you may in fact hit one or both of those large blood vessels, and the patient will have a major problem. You can find the iliacus muscle here on the rim of the pelvis, and much more commonly you can find this trigger point here. This is the major flexor of the hip, and when that muscle appears weak, it's often because there are trigger points in both the iliacus and the iliopsoas. The iliacus joins the psoas to forms the iliopsoas down here. This is often, a patient will tell you they feel a little weakness here, maybe a little anterior thigh pain, and they rub their back right up and down here, saying they feel this sort of vague pain there. And that's the referral pattern. Hamstrings, again, you're going to look for these. And one of the secrets to find some of these trigger points sometimes is simply to put the muscle under a little bit of a stretch, and something which was not painful at all is suddenly very painful. And you can then find these trigger points. If the muscles aren't too tight, you can bend the knee and release these a little bit, and you can find these by pincer palpation. And you can see where the referral patterns are to the back of the knee and up to the lower area, just behind the, just below the buttock. And the adductor muscles, you'll find them along in here. Adductor magnus and longus are the primary ones you'll see, which will give you pain just above the knee and into the groin area. These are often, the adductor muscles are often the ones that give you groin pain, especially in hockey players or in weekend soccer players. Just inactivating these trigger points will usually resolve that groin pain. The same thing here, a so-called hamstring pull is usually resolved by dealing with all the trigger points that are activated. And you can find them fairly easily, and you just need persistence and inactivate them one by one with a laser. And in fact, if there are 8 or 10 here, injections would be problematic. But since the patient feels no pain and there's no risk to continuing just finding these trigger points and inactivating as many as you find, you can really give the patient significant pain relief and allow healing to occur much faster than it would otherwise. And the same thing is true with the adductors and the groin pain. Also, you'll find occasionally a patient who presents with vulvodynia will also respond to inactivating the trigger points in the pectineus and these adductor muscles. They often will refer up into this area. And again, I mentioned the latissimus dorsi, and you notice where it's attached. So if this muscle is tight, it's going to maintain a lot of the trigger points down in here in the low back, even though it doesn't refer pain down to there. You'll find a lower trigger point and an upper one, and usually this is the one that's the most active, the one up near the axilla. Clinical problems that you can see with low back is sciatica, pseudosciatica, as I mentioned, and low back pain. You can see hip pain with the quadratus lumborum, and as I mentioned, groin pain, and often mistaken for kidney stones or L4-5 radicular pain. And the latissimus dorsi connection is clearly there frequently. What I'd like to do before we go to questions, unless there are some active questions now, I'd like to go to the case report. Excuse me, let's see here. Oh, we didn't get to the case report here. Let me go back. And we'll, I'll just go over the, we'll move through it quickly here. I'll just mention quickly a case report of a patient I saw recently who was referred to me for low back pain and also for carpal tunnel, which we've had discussed before, and which is an ideal type of case for use of the laser, since that is the study which got the ML830 approved for use for the treatment of carpal tunnel. This patient is a young woman in her late 30s or early 40s who presented with low back pain and carpal tunnel. The carpal tunnel was documented with an EMG finding of slowing across the wrist, and her low back pain had been chronic for quite some time. When I saw this patient, she again presented, as I said, with low back pain and a weak grip and tingling in the tips of fingers 2 through 5, with no symptoms whatsoever in her thumb on the right hand. She also complained of back pain that had been there for a number of years and had been intermittent in terms of its severity. At the time of my taking the history and doing her exam, she also mentioned that she had been, or she is a diabetic that is insulin resistant, and her blood sugar had never been over 180, but she actually had a total numbness of both feet from the ankles down to include the whole foot on both sides. When I examined her, she had a negative straight leg raising test. She had slightly diminished deep tendon reflexes at the knee and at the ankle. She had no Babinski